Hello, everyone. I'm really happy to be here today to talk about economic variables in the CMS claims files. It's really an important use of Medicare data is for analyses that investigate the cost of healthcare. And so today I'm going to be providing some information on how to use these variables, and I'll provide some examples of how I've done this in my work. Okay, and feel free to interrupt at any point with questions you might have. So to preface this presentation, I will just say that Medicare data has been really a very useful tool for me for embarking on research studies in health economics. So, of course, it goes without saying that Medicare claims data includes really extensive information on healthcare use, which is of great importance. And, of course, it also includes extensive information on the costs of that healthcare that is used. And so that includes the costs of healthcare to Medicare based on the payments that it makes to Medicare makes to healthcare providers. And I should just add here that I'm talking about traditional Medicare today. So of course, in the most recent Kaiser Family Foundation data, 50% of Medicare beneficiaries are now enrolled in Medicare Advantage, so they receive their healthcare from private, or their healthcare is covered by private Medicare Advantage plans, and data for those enrollees is also available, but that's sort of a whole different course. So Medicare data also includes information on the costs to healthcare providers for providing healthcare services. And then it also includes information on Medicare beneficiaries' out-of-pocket costs. And then I'll also just add that Medicare data also includes some measures of beneficiary health and functional status, and we'll talk about that a little bit as well. And then, of course, the master beneficiary summary file includes some basic data on demographics and economic status. So economic status here we're talking about is like income-based eligibility for programs such as Medicaid and the Part D low-income subsidy. And in addition, you can tell where Medicare beneficiaries live, which can be linked with information on different communities. So overall, this is really a rich source of information for research studies. And so just to provide a couple of examples, so, I've used Medicare data to evaluate various Medicare programs and policies, and that has been, you can really say quite a bit about different policies. But I'm also currently involved in an effort to use Medicare data in order to perform long-term surveillance of participants in a clinical trial. So using that data, we're able to sort of these trial participants, we're able to link them to information on their healthcare use, of course, but also information on their functional status and comorbidities and things of that nature. So really, I think there are a lot of interesting things you can do with these data. Okay. So just to give an overview of this section, I'm going to describe some of the useful fields in claims data for economic research. In particular, I'm going to be focusing on the inpatient file and the MedPAR file, the carrier file, and the outpatient hospital claims files. And for each of these examples, I will discuss some relevant and related Medicare payment policies, this is important for understanding the payment information that's available in the claims data. I will also be discussing the different measures of costs that are available in Medicare data. We'll discuss some of the payment adjustments that you see in Medicare data. And finally, we'll talk a little bit about how to perform cost effectiveness analysis and comparative effectiveness research using Medicare data. Okay. So I think before we dive into some of the data details, I think it's useful to take a moment to reflect on how health insurance claims data are generated, and particularly in the Medicare context, in order to understand the source of the data that we are analyzing and considering. So on this graph, there are three entities. So first, we have consumers or patients in the blue circle who are receiving healthcare services. Second, we have the third-party payer for healthcare. So this could be a private commercial insurer, or in this case, I think we're more interested in a government agency or public payer such as Medicare, which is shown in the orange circle. And finally, we have the third entity, which includes the providers of healthcare, shown in the green circle. So the first step in the story of us obtaining claims data is that consumers or patients are going to be paying a premium to Medicare. So this is in particular for Medicare Part B, and which is medical insurance, and Part D, prescription drug coverage. This is usually premiums are zero for Part A. And so consumers or patients are paying these premiums in exchange for health insurance coverage. And then the next relationship in this schematic is the relationship between consumers, patients, and their healthcare providers. And so after healthcare providers provide medical services to patients, the patients are going to, typically, even with Medicare, they're going to be paying some out-of-pocket fees back to the hospital or physician or other provider. And then after that service is provided, healthcare providers will be submitting charges for what this service costs them to provide, and other information on the services provided to patients and the patient's health status. And then in exchange, they're going to receive some payments from Medicare. Okay, so this is the claim generating process, and the information that we see in the Medicare claims data. So first, it's going to describe the medical services that were provided, as well as, in many cases, the patient's health status. We're going to see the charges that providers submit to Medicare for those services. We're going to see how much healthcare providers were paid. And so altogether, this is quite a bit of information about healthcare service use in the Medicare program. And, of course, we see the health insurance coverage information in the master beneficiary summary file. So all told, really a rich source of data. So I just want to briefly summarize for you the types of economics information data that I use in my research when I'm using Medicare data. So first, the types of Medicare coverage that patients are enrolled in is extremely important for any study in terms of defining the study sample the question that you will be answering. So, as you know, a key example is is a beneficiary enrolled in optional Part B or Part D coverage? That's very important. Does an individual receive coverage through traditional Medicare or a private Medicare Advantage plan? And for that matter, is an individual, what Medicare Advantage plan is someone enrolled in? And so you see that information in the master beneficiary summary file. And in fact, that's really important for some work I'm doing right now. And the other thing is whether someone is enrolled in Medicaid supplemental coverage is also quite important information. So it does say something about an individual's economic status, that they are eligible for Medicaid. So next, I think of great interest is the fact that a service was provided to a patient. So did a Medicare enrollee have a hospital admission, or an outpatient office visit, or an emergency department visit? And for that matter, you can also see the various services that are provided during a given hospital stay. And so, for example, if you're evaluating some kind of Medicare value-based payment program, you may be interested in sort of understanding whether enrollees are using more outpatient office visits and fewer hospital services. And so, so these data on their own are quite interesting. So third, as mentioned previously, in these data, we can see the cost of services, be it to providers, patients, or to Medicare. And then finally, we can see outcomes of the different services provided in terms of health and functional status, although these data are like a little bit more limited in administrative data like Medicare data. Okay, so with that overview, let's go into a bit more detail about specific economic variables that are present in specific data files. So let's start with the inpatient claims and the MedPAR files, which include data on hospital stays and post-acute care stays. So in my experience, we can start this by talking about some of the important fields that are present in the inpatient and MedPAR files. And the data that I actually use the most in these files is simply the fact that a hospital stay or a post-acute care episode occurred. And so, in the MedPAR data, along with the hospital stays, we also see skilled nursing facility stays and also inpatient rehabilitation facility stays. Along with the fact that a given stay occurred, you can also see, in the case of a hospital stay, why did that hospital stay occur? And so the key field here is the Medicare severity diagnosis, or Medicare severity related diagnosis group, or the MSDRG. And so the MSDRG tells you both the primary reason for a hospital stay, but then also a patient's disposition. And so this is specifically indicating whether a patient had complications and comorbidities or major complications and comorbidities. And then closely related to the MSDRG is the key condition or procedure which led to a particular hospital stay occurring. And then finally, you can see how long was the hospital stay, different procedures that were received during the hospital stay, and other information. And so I mentioned this is like the data I use the most, and I think there are various reasons why this is so useful. So in some cases, you can use, I've used the MSDRG to define the sample for a given analysis or study. So for example, if you are interested in understanding how some intervention or policy affected post-acute care use, you may focus on patients hospitalized for a few different conditions. And so you can define your sample based on the fact that these patients were admitted for a given MSDRG. A second reason you might be interested in this data is that it is a utilization outcome for a given study. So you might be interested in how a given policy affected hospitalizations for ambulatory care sensitive conditions. And those classifications are based on diagnosis codes that you can see in the inpatient or MedPAR files. And so that's very useful. And then finally, I just want to note that there are some conditions that are nearly always hospitalized. So if you see that someone was hospitalized for that condition, you can sort of assume that that health event happened. So for example, if someone has a heart attack, they are nearly always admitted to the hospital, or similarly for a stroke. And so this is actually a way to sort of measure patient outcomes using Medicare data. And so then beyond the utilization information, you can see the cost of the hospital admission or post-acute care stay for the provider and for Medicare and the beneficiary. So we can dive into that in a bit more detail. So the first information here is the provider charges. So does anyone, would anyone say that provider charges is a good way of measuring the cost of a service in Medicare data? Does anyone think this is a good way to measure costs? Let's see, we got it in the chat. No, from Michael. No, yes, everyone says no. That is correct. So you see these data in the claims, but they should not be used to reflect, to understand the cost of a given service. So this example on this slide shows the average charges for MSDRG 194, which is simple pneumonia and pleurisy. And so this table shows that the average charges for the service were $28,000, which is quite high. The key thing here is that this charge really only reflects the actual payment to a hospital in the case of uninsured individuals, which is really kind of an unfortunate occurrence because the charges are so high. And in particular, hospitals actually in some cases can use these charges to ramp up payments for hospital care. And there was actually a paper about this. I was at the American Society of Health Economists meeting last week, and there was a paper about this. So I think that this charges can be gamed by providers and really shouldn't be used by themselves to measure costs. So what do you do with this information? So one thing you can do to measure provider costs is to use a cost to charge ratio. And so the cost to charge ratios are available for hospitals in Medicare cost reports. And so these ratios basically represent the ratio of charges to allowable costs. And so if you apply if basically you see this $28,000 and you say, well, the cost to charge ratio was 3.4, so this was the national average, and in 2015. So, you divide that by the $28,000 by 3.4, and you get the allowable cost. And so one issue with the cost to charge ratios is they are based on, there's some lag in terms of the costs that are used to create these ratios, but it's an approximate way to figure out actual costs from charges. But I think another important point is that what Medicare pays for a given hospitalization is not based on charges at all, and so we'll discuss that next. Are there any questions on charges? Okay, so how does Medicare pay for hospital stays? And the answer is that Medicare pays a fixed per stay payment for a hospital stay based on the MSDRG, which we described before. And so this is defined by the principal diagnosis or procedure and the presence of complications or comorbidities. So the goal of this prospective payment, so it's called the inpatient prospective payment system, is that the payment rates are intended to cover the costs that reasonably efficient providers would incur in furnishing high quality care. And so beyond this kind of base rate for a particular MSDRG, is like that rate is also adjusted based on other factors, such as, for example, geography. So a hospital that is located in an area of the country that has higher wages would have a higher payment rate for a given MSDRG. Other adjustments include if a hospital is training medical residents, then they will be receiving indirect medical education payments. And also, if a hospital treats a high proportion of lower income patients, they'll also receive a higher rate. And then finally, there are these other policy adjustments, which basically reflect the performance of a hospital in the hospital value-based purchasing program and the hospital readmission reduction program. So better or worse performance on quality of care and hospital readmissions will lead to a higher or lower rate. And then I guess finally, there are payment adjustments for short stays and transfers. And so those types of stays would have a smaller payment, but then also there are adjustments for which are known as outlier payments for extremely expensive stays as well. And I think the key takeaway of the prospective payment system for hospitals is that a given payment may or may not cover the actual cost of a hospitalization to the hospital. So beyond the really extraordinarily expensive stays that receive outlier payments, there aren't additional, the payment to the hospital is really not related to the cost. And so this creates some incentives to really provide services during a stay efficiently and also limit the length of stay if possible. Okay, there were a couple of questions. So Theodore had a question about what is the purposes of the charges. And so there are actually some uses of the charges by Medicare. So I mean, a key example is to It figures into the formula for how outlier payments are determined, but it's tricky. I think the charges aren't that useful, but with the cost of charge ratio, they have some utility, I suppose. Another question was from Philip about the ratio changes and how do you track the changes. And so what you can do for this is, I think my suggestion would be to, get the most current ratio using the most recent hospital cost reports from a given year. And, I think it's a little tricky. It depends on the exact research question you're using. So if you are looking at data over a long period and you have charges from each year, then you have to make a decision about, which cost to charge ratio to apply. Do you apply each year's cost to charge ratio, or do you apply single years? And so I think it probably depends on the specific research question. Okay. Okay, so let's move on to the another measure of cost that is available in MedPAR and the inpatient file, and that is the patient's share of a hospital or post-acute stay. And so one piece of this is that you're able to observe in MedPAR is the Part A deductible. And so for each spell of illness, a patient is responsible for this deductible at the outset. In 2022, that was $1,556. It's $1,600 in 2023. And then beyond the deductible, there is coinsurance. So the first 60 days of hospital care, there's zero coinsurance. As you have more days in the hospital, coinsurance kicks in at 61 through 90 days, and it goes up after 91 days. And so there is actually, as you can see from this slide, there really is substantial cost sharing if a patient has traditional Medicare coverage, but no supplemental coverage. But there are these sources of supplemental coverage, such as through Medicaid or Medigap, and of course these Medigap plans help pay for this substantial cost sharing. The tricky thing is that you can't see enrollment in Medigap coverage in the Medicare data. And so it's actually a piece of the puzzle that is sort of missing. And so that's a little tricky. So it's just something I want to flag for you all to be aware of. Okay. So Kevin had the question, are these adjustments made on a per claim basis? That is correct. Well, some of the adjustments, yes, I mean, all of these adjustments are visible in the claims. So you can see the dish payments, and you can see, but then you also have a total claim payment amount, which includes all of those adjustments. Okay, Justine had a question. If we were to look at costs associated with a group of diagnosis codes for claims in the inpatient LDS SAF, how would we do that? So Justine, your idea here is that you're interested in like hospital admissions for a particular diagnosis or group of diagnoses. And so are you interested here in the costs to Medicare, or the costs to the providers? Both. Okay, so I think for the cost to Medicare, you could use the claim payment amount to get a sense of the average cost to Medicare across admissions for that diagnosis code. For the cost of providers, that would be a bit more complicated, but you could use cost to charge ratios to apply them to the charges you see in the inpatient LDS, and that would sort of deflate the charges and provide a measure of cost, and you could find the average cost in that way. Does that make sense? Cool. Okay, so now let's talk about the carrier file, which includes claims from professional providers. So there's a lot of important information and helpful information in the carrier file. You can see the healthcare utilization, and here the sort of identifying field, instead of being the MSDRG, it's the healthcare common procedure coding system, or HCPCS codes. And so this is telling you at the claim line level what services were provided to a beneficiary. You can also see the charges that were submitted by providers, and then the allowed charges, and these are available at the line and claim level. You can see what Medicare paid providers for each service, again at the line and claim level, and you can see the beneficiary's portion of this payment, so their Part B deductible and coinsurance on each claim. So first, let's just talk about the submitted charge and the allowed charge on the carrier file. And so the allowed charge is basically going to be equal to the I believe the actual payment amount from Medicare to the provider plus the cost sharing paid by the beneficiary. One kind of interesting thing here is that you can, if Medicare denies a given line item, so a given service they're saying that this isn't, this shouldn't be covered. You can see that the allowed charge will be 0 here. Let's now talk. So that's what the provider says the service costs. Now let's talk about the cost to Medicare for services from professional providers. So basically, Medicare is paying professional providers based for a given service defined by HCPCS code, based on the relative value units of that service. And so the relative value units are defined as a function of the clinician work effort in terms of time and effort and skill and stress. It also incorporates practice expenses. So running this given clinic and how much that is associated with a given service. And it also covers professional liability insurance. And then there's kind of a base conversion factor, and then there are these different modifiers. So there is a payment modifier, which is applied when multiple procedures are provided, then the rate is lower at a given time. Sort of similar to the hospital payment system, there are geographic adjustments that reflect that wages are different in different areas of the country. and they're adjusted for the provider type. So a doctor versus a physician assistant or nurse practitioner. And then finally, there are these adjustments for the quality payment program. So, are you all familiar with the quality payment program in Medicare? So basically, over many years, like spending on professional services kept increasing and increasing, and Congress tried to come to an agreement for how to like control these costs, and they had these automatic cuts that were going to go into place, but they kept suspending those cuts from going into effect, and so then they finally came to an agreement in 2015 with the quality payment program. And so the idea here is basically that if you're a physician, your payment rate can be affected. It's adjusted on one of two tracks. And so if you are participating in a kind of a value-based payment program, like for example, a bundle payment program or an ACO, accountable care organization, where you have like basically, you're facing some financial risk for your patient's healthcare use, then you receive automatic payment rate increases through the advanced payment model track. If you're not participating in an ACO or a similar program, then you're on the merit-based incentive payment system track, which is basically like a pay-for-performance system, where depending on your performance on an array of different measures of like efficiency and quality of care, if you're performing well, then you receive positive adjustments. If you're not performing well, then you receive negative adjustments. So that's another adjustment that happens to professional providers' payments by Medicare. And so this is just this flow chart kind of just shows the complicated process by which an individual clinician's payment rate is determined for a given service. So you see there's this, there's a base conversion factor, and then all these adjustments based on the work and practice expenses and liability insurance and the complexity of the service, and the provider type and the geographic wage index. And then at the end are these adjustments for the participating in an advanced alternative payment model or participating in the pay-for-performance type program in the merit-based incentive payment system. So it's quite complicated, but this is the process by which you get to the payment you see in carrier claims. Okay. So a couple of other notes about physician payments. So if you are a physician working in your own office, then you'll receive a higher rate for a given service than if you worked as provided the same service as a part of for example, within a outpatient hospital department. So here for this colonoscopy, HCPCS code 44388, the price not in a facility, so in an office, is $303.45. That same service in a outpatient, in a facility, it's only $164.34. And what this is basically representing is the fact that there are these practice expenses, and so the practice expense RVUs in a non-facility are 5.27. In a facility, they're 1.41. And so then basically it's just that leads to the total non-facility RVUs being higher than the facility RVUs, and so the payment rate is higher. Okay. All right, any questions on the physician payments in the carrier file? Okay. Okay, the next file is the outpatient file. And so the outpatient file is kind of gets to those facility claims we were talking about in the previous slide. So basically, if a physician is providing a service in an outpatient hospital department, there will be one claim from the physician, a professional claim, but then there will be another claim from the outpatient hospital department, and that's the institutional claim. And it covers the institutional portion of the cost of providing that service. And so, okay, what are some of the important fields in the outpatient file? So similar to the carrier file, you have the HCPCS codes, which tell you the type of service. You also have revenue center codes. And this is really helpful because it tells you whether a given service was provided in an emergency department or within an observation unit, for example. So you can tell, like, this is a great way to identify, whether a given individual had an emergency department visit. You can also tell, again, like what the institutional provider charged Medicare for the services, what Medicare paid for the service at the line level and the claim level, and what was the beneficiary's payment responsibility for a given service. So let's go into this in a bit more depth. So let's go straight to how Medicare pays outpatient hospital departments. So Medicare has a prospective payment system for outpatient departments. And the unit of payment in this system is called the ambulatory payment classification. And the idea here is that if you have a number of similar services, so like HCPCS are mapped to APCs, these are, you get a set payment for that package of integral services. And so it creates some incentive to, within an APC, use services efficiently. And so kind of similar to the professional payment methodology and the hospital payment methodology, these outpatient prospective payments are adjusted using the hospital wage index. There's an APC weight, which indicates, the cost of a particular type of APC. And then there are also quality and policy adjustments. So the next, moving to the beneficiaries' share of the payment. When you're thinking about these outpatient facilities, this falls under Part B as well, whereas the inpatient facilities are Part A. So there's a deductible, which in 2022 was $233. There's co-insurance as well. So this is actually kind of a big deal. So Medicare pays 80% of the service cost, and then 20% is the patient's responsibility. And so this is a place where, that 20% can really be a lot, and supplemental coverage is quite important for enrollees in traditional Medicare. So when you see the allowed charge in the carrier file, as I mentioned, this is generally equal to the patient's share of payment plus what the Medicare payment was to a provider. And then in the outpatient file, the copayments are a little different compared to the carrier file, where it's like there's basically coinsurance, which will be either 20% or less, which is set by statute. So approximately the copayment is 20% of the APC rate. Okay. Any questions on the outpatient prospective payment system? Okay. So let's just talk a little bit about what cost to use in a given context. So we talked about, you can look at, you have a given health service, you can see how much that service costs to Medicare based on what Medicare paid the provider. You can see what it costs to individuals based on their copayments and deductibles and or coinsurance. But then you can see what was the cost to a provider. And so I think depending on the specific research question, you'll use a different measure of costs. So if you're sort of interested in, there was a change in payment methodology, and you're kind of interested in do providers ramp up or ramp down the intensity of care in response to that change in payment methodology, then you'd want to use provider costs, and you'd have to take the charges and adjust by the cost to charge ratio. If you're kind of interested in the question, okay, Medicare, for example, Medicare changed the way they paid for home health, and I think it was 2019. And so it went from a 60-day prospective payment to a 30-day prospective payment. If you're interested in how did that payment change affect Medicare's spending on home health, then you'd want to use payments. So it really just kind of comes down to the research question. Theodore, you had the question, are the various payment algorithms transparent? As I could know what Medicare will reimburse for any hypothetical claim. So I will say that they are very complicated, but they are transparent, despite the fact that they're complicated. And so I think if you want to know, I think there are two levels to get at what the reimbursement would be for a particular service. If you kind of just want the high level information, I would go to the Medicare Payment Advisory Commission is the group that advises Congress on payment policy. And they have these really great, they have this publication series called Payment Basics. The idea being here, they have to teach Congress how Medicare works so that, Congress members can make informed decisions about Medicare policy, which is very complicated. And so they have, I think that those publications are excellent for sort of getting a high level, but yet still quite detailed description of how different payment policies work. And they go down to some granularity. Now, if you were saying, I want to know how much, what would the payment be for, Mr. Smith in Minneapolis, Minnesota, getting a joint replacement at the University of Minnesota Hospital with these comorbidities and these complications. You could figure that out. It would be kind of complicated, but you could do it. All of the data all the payment adjustments are all on the CMS website. There's this hospital file called the impact file. That includes, I think the wage indices. There is a DRG file that says like what is the rate for each DRG. So it's complicated, but I think it is transparent. Does that answer your question, Theodore? Cool. And okay, cost to individuals would give us the out-of-pocket liabilities, not the actual spending. So Asal, is your question like this is what they owe whether or not they pay it? Is that right? Yeah, I think it is the liabilities. I'm pretty sure that's right. That's a good question. I'll look into it. And there was an earlier question too about like how long does it take for Medicare to reimburse a claim after it's submitted? And I'm not sure the answer to that either, but that's an interesting question that I should know the answer to. Oh, cool. Thanks. That's great. Okay, so I think we're running a little short on time. How much time do I have, Steph?
It was scheduled to end at 2:30.
Oh, okay.
A little more time.
Okay, I'll go through the last stuff kind of quickly. So I think one point I just wanted to make is that it used to be that costs and payments would go in the same direction because it was fee-for-service reimbursement. So like when costs went up, payments went also go up. But now there's more and more episode-based payment, bundled payment, and so like the payments and costs like don't track as well as they used to. And this is just an example of that. So this is kind of an old paper now, but I think it shows the example. So we were looking at the effects of two different home health payment reforms. The first basically kept a per visit payment, but imposed limits on the payments. And so basically both the payments to home health agencies and the costs they incurred went down. But then there was a shift to an episode-based payment system. And so that actually increased the average level of payment. So payments went up, but then, it was a prospective payment and home health agencies would keep whatever they didn't use. And so the costs, like the resource use, stayed the same. I mean, the difference here is kind of like the margin, the profit margin. So it's just something to think about. Okay, because just given that I'm short on time, I think I'm going to skip over the payment adjustments, but I guess I will just say that there are all these adjustments for different policies, and that could affect hospital payments or they could affect physician payments. And there are some of them you can identify in the claims data. Others are hard to identify in the claims data. And so I think if you have a specific question about this, I would review the slides and email any of us or ResDAC, and we'll get you the best answer we can. All right, so I'm just going to briefly talk about performing cost and comparative effectiveness analysis with Medicare data. So cost effectiveness analysis is basically telling us we're comparing maybe two healthcare interventions, and we want to know, okay, is one more beneficial than the other? And if it is the new cost per benefit extremely expensive? And so, usually the benefits here are given in terms of quality adjusted life years. And so we basically look at the ratio of the changes in costs per quality adjusted life year. And we say it's, the intervention is effective if that ratio is less than $100,000 per additional life year. And then comparative effectiveness research is kind of similar, but it's just looking at the benefits. It's just saying, is this technology or intervention, more effective than another technology? And so, these are both important evaluation approaches for new health interventions or technologies. And so the question is, can you measure this with Medicare data? So the costs we can get, right? Like we see those in the data. We see payments, we see provider costs. So we're good to go on the costs. The benefits are tricky. So we don't see quality adjusted life years. We do see mortality. So we can look at that as an outcome. We can look at, we can actually, using institutional claims and nursing home data, we can determine whether someone resided in the community versus being in a nursing home or a hospital. So that's actually like a decent measure of functional status. We can also look at, different measures of morbidity. So length of stay. We can look at readmissions after hospital or post-acute stays. So those are kind of measures of outcomes. I guess there are other measures. We can see functional status, but only for people who live in nursing homes or in receiving home care. I will say that the current beneficiary survey, the MCDS, is great because it includes a lot of information on health and functional status that you can't get in the administrative Medicare data because it's a survey that is linked to Medicare data. I think I guess the takeaway is there are some good outcomes you can look at, but it's you can't answer every question. Okay, so feel free to contact me or ResDAC if you have questions on any of these topics. Thank you very much.